Welcome to the Ophthalmology Review for VAPA's Conference 2021. My name is Nancy Reed. I'm a physician assistant and I currently work for the University of Lynchburg's Doctorate of Medical Science program. This is an ophthalmology review that is an abbreviated version following the PANTS and PAN-RE blueprint. I'd like to first say I have no relevant commercial relationships to disclose. We're going to start first with a review. I like to tell people, if you don't pay attention to anything else in this entire presentation, this review slide will help with about 50% of the questions on a PANTS and PAN-RE exam, just if you know this slide alone. So the first, we're going to review the cranial nerves. Cranial nerve 3 opens the eye by innervating the levator palpebral muscle, and it is also responsible for pupil constriction. Cranial nerve 7 closes the eye and is responsible for tear production. And cranial nerve 2 transmits visual information from the retina to the brain. And now I like to use the acronym, which I'm sure most of you were taught in PA school, LR6SO4R3. And that stands for the lateral rectus is innervated by cranial nerve 6, the superior oblique is innervated by cranial nerve 4, and the rest are innervated by cranial nerve 3. Oblique muscles are named for where they attach on the eye and not how they move the eye, and that is what gets people kind of confused. The inferior oblique is attached at the lower portion of the eye, but yet pulls the eye superiorly. And the superior oblique does just the opposite. It moves the eye inferiorly. And the last thing is, if it involves the lid or the pupil and the eye is down and out, it's cranial nerve 3. So if you ever read any kind of clinical scenario question and it says anything about the pupil, the lid drooping, or the eye turning down and out, cranial nerve 3. Let's talk first about lacrimal disorders. And we're going to talk about Dacryocystitis. And just a little review of the lacrimal system. Tears are produced in the lacrimal gland in the bony, that sits just below the bony orbit of the eye. And the tears wash over the eye, hydrating the eye, and then they drain into the puncta. And then from the puncta, they drain into the canicula, and then the lacrimal sac, and then into the nasolacrimal duct. Dacryocystitis is an infection of the lacrimal sac due to obstruction of the nasolacrimal system. It's generally unilateral, and there are 2 times in people's lives that they get it. It's a congenital problem for some, and it also becomes an acquired problem more commonly for females who are greater than 40. The etiology is usually an acute is Staph aureus or beta hemolytic streptococca. In a chronic condition, it's usually Staph epidermidis, anaerobic streptococca, or Candida albicans. And signs and symptoms. It includes pain, swelling, tenderness to palpation over the lacrimal sac. And you have to be careful if you palpate the lacrimal sac. Make sure you're wearing eye protection because purulent matter can be expressed back at you. And when it comes through the puncta, it can spray. Treatment includes systemic antibiotics if you treat it medically. Sometimes people have to have surgeries. And if you have to treat it surgically, adults have dacryocystostomy, which is the fistulization of the lacrimal sac into the nasal cavity. And pediatric population usually has a balloon dilation or a simple. Here's an example of a child with dacryocystitis. The picture in the upper left-hand corner shows a swollen lacrimal system, and on the upper right-hand corner, you can see a lacrimal probe or balloon dilation just below that. So dacryocystitis can oftentimes be confused with infectious orbital disorders. And the two infectious orbital disorders that we're going to talk about are periorbital cellulitis and orbital cellulitis. So periorbital cellulitis, there's typically a history of a break in the skin around the eye. Maybe the person has had an infected chalazion, or it can be an extension of conjunctivitis or sinusitis. Signs and symptoms include erythema, edema, discharge, teary eye, fever, and reduction of vision. This is typically seen in kids under 2. In the etiology is if it's a preseptal infection, meaning in the forward portion of the eye, it's caused by Staph aureus, strep pneumonia, streptococcus, and MRSA is on the rise. With the H flu vaccination, the causative agent of H flu has decreased in incidence in the past years. Periorbital cellulitis, you do imaging, and with imaging, a CT scan is often needed to be able to differentiate periorbital cellulitis from orbital cellulitis. And on imaging with the periorbital cellulitis, there's no fat stranding of the orbital contents. There's no involvement of the extraocular muscles, and there is typically eyelids swelling but no proptosis, where the eye is basically being pushed out of the socket. And so when the extraocular muscles are not involved, then there's not pain with extraocular movements. So treatment for periorbital cellulitis typically is treated in an outpatient setting with antibiotics. You might have to hospitalize children younger than 1 year old or those who look critically ill, and you target the antibiotic. You use the antibiotic by targeting what you think the causative agent is. Children younger than 4 may need IV antibiotics, and if outpatient therapy fails to show improvement in about 24 to 48 hours, these guys need to be hospitalized, put on broad spectrum antibiotics, a CT scan if it hasn't been done yet, and then a surgical consultation because they may need an incision and drainage. So periorbital cellulitis is very frequently confused with orbital cellulitis. And the difference, clinically, right off the bat, is orbital cellulitis usually comes on a lot more sudden, and there's a sudden onset of fever. There is proptosis in this, where the eye is actually being pushed out of the orbit. There's pain with and restriction of extraocular movements, so you have them follow your finger, and when they look to the left, look to the right, look up, look down, they will complain of pain, and they may not be able to do all the extraocular movements. There's usually edema and erythema of the lid. This is also usually seen in kids, but these guys will have a history of a paranasal sinus infection. And the causative agents for that is Staph pneumonia, H flu, and Staph aureus. This is an urgent referral, and these guys need to be put on antibiotics to prevent spread to the cavernous sinuses, meninges, and brain. So the picture on the left is the young girl trying to do extraocular movements, and you can see that she does not achieve all the extraocular movements in the left eye that the right eye can do. And on the right hand side, this is her CT scan, and as you can see here, one eye is actually being pushed forward out of the socket because of the infection behind it, and that's the proptosis. And again, that's later on down the line. Hopefully, you catch this before it gets to that point, but that's what proptosis looks like. So here's a little chart that I think is super helpful. This is periorbital cellulitis versus orbital cellulitis. So it's just a comparative chart. The pathogenesis for periorbital cellulitis is usually some sort of trauma, whereas in orbital cellulitis, it's a preceding sinusitis. Periorbital cellulitis usually happens in a younger population, around 21 months, whereas orbital cellulitis happens in an older population of 12 years. And clinical findings, you're going to have that proptosis, and you're going to have restrictions of the extraocular movements with the orbital cellulitis. So the three conditions we just talked about, here's a comparison of each of those three conditions. And if you just look at the patients, you don't talk to them, you don't get any history, the Dacryocystitis and the periorbital cellulitis, in my opinion, looks a lot worse just staring at the patient than the orbital cellulitis. But clearly, the orbital cellulitis can be life-threatening. And people get confused with this all the time. They'll have somebody come in with a periorbital cellulitis, a dacryocystitis, and just the presentation really scares them, and they will send them to ear, nose, and throat. And I will tell you, or an ophthalmologist, and I will tell you that you're better to err on the side of caution and not miss an orbital cellulitis. But I just kind of put this slide out there to don't get confused between the three just by which one looks the worst. We're going to talk a little bit about traumatic disorders now. Subconjunctival hemorrhages, corneal abrasions, foreign bodies, and hyphemas. So subconjunctival hemorrhages, I'm sure you guys have seen many of those. They don't affect the vision. There's minimal symptoms. The patient does get lots of attention. And the one thing that I just want to print out here, and this is why I added this slide, is you can see that on subconjunctival hemorrhage that the hemorrhage stops at the limbus. This is the edge right here is the limbus. And there's nothing to do for these. Unfortunately, though, people will freak out. You try to reassure them. It looks so awful. And you just have to continue to reassure. Corneal abrasion is simply a scratch on the cornea. The signs and symptoms typically include redness, tearing, and a foreign body sensation. And most important thing, if you think you have a corneal abrasion, you have to evert the eyelid and make sure that there's not a foreign body stuck to the eyelid. And that every time, because if it's stuck to the eyelid, you can't see it. And every time they close their eye, they're scratching it even more. And you should do a slit lamp exam with fluorescein dye. And the treatment for this is broad spectrum antibiotics or ointments. And that's trimethoprim and polymyxin B. If you have a contact lens wearer, you must cover them for Pseudomonas. So a gentamicin, a tobramycin, or ciprofloxacin. So here is an example on the left where that foreign body is actually stuck to the underneath surface of the eyelid. And on the right, on fluorescein stain, you can see every time this person opens and closes their eyes, they scratch the cornea even more. So make sure you flip those lids around on physical exam and try to identify if there's anything on the underneath side of the lids. So foreign body, you fluorescein stain, if not able to see with the blind eye. Sometimes you can just see a foreign body with the blind eye. If you can't, you definitely want to do a fluorescein stain and make sure you inspect the lids. One way to get a foreign body off is you just remove with a sterile wet cotton tip. So just take a sterile cotton swab, wet it with sterile water, and try to sweep it off of the eye. If you have a foreign body that is made of steel, these can leave rust rings, and this needs to be removed by an ophthalmologist. So we recommend that they follow up and get examined by an ophthalmologist with 24 hours, even if you get the foreign body off. And then clearly, intraocular foreign body gets an emergent referral to ophthalmology. So here is a foreign body on the cornea, and here is an intraocular foreign body. So let's talk just a little bit about this corneal foreign body. Whenever foreign bodies are close to the limbus is where the cells for the cornea are regenerated, and cells for cornea are regenerated fairly quickly, and they move from the limbus toward the center of the eye. So if you have a foreign body that's close to that limbus and it's been in there for a couple of days, what happens is some of the cells actually grow over the foreign body and encapsulate the foreign body. So removing those with that wool or with that cotton tip applicator is going to be a little bit harder, and you may not be able to get it out. You may have to refer these to ophthalmology because a layer of cells has grown over top of the foreign body and encapsulated it. So timing here is really important in position. So the closer it is to the limbus and the longer it's been there, the greater the likelihood there's a layer of cells that has encapsulated that foreign body. Hyphema is blood in the anterior chamber, and this can increase the intraocular pressure. It's typically caused by eye trauma. We see this a lot in sports injuries, accident or home or work accidents or falls. Signs and symptoms include pain, photophobia, blurred vision. Treatment, this is typically an emergent referral ophthalmology because we have to make sure that there's not increased intraocular pressure. And we treat this medically with topical cycloplegics and corticosteroids. We put on a rigid shield and we limit activity. Sometimes if the intraocular pressure is rising, you may have to go to surgery. Also, there could be presence of corneal blood staining, so the blood is actually staining the cornea, which will then long-term prevent good visual acuity. So we have to watch those two things, and sometimes those require surgery to alleviate the hyphema. So here's an example of a hyphema. In this picture on the left, you can clearly see the blood level. And again, as that blood level rises, you can have a rise in the intraocular pressure. Now we're going to talk about some anterior eye disorders, Hypopyon, Pterygium, Pinguecula, Cataract, Keratitis, Corneal Ulcer, Episcleritis, and Scleritis. Hypopyon is just like hyphema, but instead of blood in the anterior chamber, there's pus in the anterior chamber. And this can be caused by infection of the iris or uvea, which can be caused by both systemic as well as local conditions. Some causes include tuberculosis, HSV, Lyme disease, MS, chickenpox, or psoriatic arthritis. So you have to try and figure out what's causing it, and then you have to treat the underlying cause. And again, you have to watch for increases in intraocular pressure, and many times these have to be referred on to ophthalmology because of that. Pterygium you'll see quite frequently in your practice. They're a fleshy, triangle-shaped tissue that can encroach on the cornea, and as long as it's not encroaching on the cornea, there's nothing to do for it. It's typically associated with wind, sun, sand, and dust exposure, and it's fairly common in the Southwest United States. Treatment, you only treat it if it starts to affect the visual acuity and it's encroaching on the cornea like you see in the picture below. And many times, even if you remove this tissue as it is encroached on the cornea, a lot of times it will come back. So, but in general, the best thing to do is try and prevent exposures to wind, sun, sand, and dust. And you do that by having these people wear sunglasses. So you'll see a lot of farmers with this, a lot of migrant farm workers with this because they're out in the sun all day and having exposures. Pinguecula is just a yellow elevated nodule on either side of the cornea. Most commonly, it's found on the nasal side, and it's common in people over age 35. A pinguecula rarely grows, but inflammation may occur, so it kind of just stays the same size. Sometimes it gets inflamed and might enlarge just a tiny bit, but it'll go back down. And treatment, again, for this is artificial tears. You can do a short course of topical NSAIDs, but most generally, it's just reassurance to the patient. There's nothing pathological there. And here's another close-up look of a pinguecula. Cataracts is a lens opacity that causes blurred vision and gradual loss without pain or redness. And etiology is typically increased age. You can have congenital cataracts, and if you do experience cataracts, you see cataracts in a newborn, it's usually because they've been exposed to rubella or CMV in utero. But in senile cataracts, which are seen in older patients, its age. And what happens is proteins build up on the lens, and the lens starts to become cloudy. Those who smoke and have long-term corticosteroid use are at increased risk of developing cataracts. Signs and symptoms: people will have a gradual visual loss, and as it goes on, the pupil will become white in color. Treatment for this is typically surgery, and this is when we do ultrasonic fragmentation and replacement of intraocular lens. Unfortunately, you'll see this a lot in third world countries, and this will lead to blindness generally in those areas because they don't have access to this easy surgery. So here's an example of a cataract, and you can see the white opacification of the lens. Bacterial keratitis is usually aggressive and often due to prolonged contact wearing or corneal trauma. So the keratitis is actually is just an ulceration in the cornea, and it's typically caused by Pseudomonas, strep, staph, and Moraxilla. Signs and symptoms of this is you're going to have somebody with eye pain, redness. They're going to have a cornea that's hazy, and you can a lot of times see central ulcer, and they may or may not have a Hypopyon. Diagnosis: you want to gram stain or culture these, and you treat a gram positive with a cephalosporin eye drops, and a gram negative with fluoroquinolones or aminoglycosides. So again, this is typically seen in those prolonged contact lens wearers when they're supposed to be removing it and they don't. So viral keratitis, there are two forms of this. There's Herpes Simplex Keratitis and Herpes Zoster Ophthalmicus. So Herpes Simplex Keratitis is a corneal ulcer that's caused by Herpes simplex. Signs and symptoms include they're going to have this foreign body sensation in their eye. They're going to have light sensitivity and redness and blurred vision. Absolutely, you need to do a fluorescein stain on these, and you need to make sure you document your findings. Even if you don't see a dendritic lesion, make sure, if you don't see anything, just make sure that you did document that you did a fluorescein stain, because you may document it today, there is no dendritic lesion, and tomorrow you could do a fluorescein stain and there is a dendritic lesion. So you just want to make sure that you're documenting that you do fluorescein stains even if you don't see anything. Treatment for these is acyclovir, and you never want to give these guys steroids. The steroids can actually make the herpes simplex keratitis worse. And the picture on the right-hand side is the typical presentation of a fluorescein stain of a dendritic lesion under fluorescein stain. Herpes zoster ophthalmicus. It occurs when varicella zoster virus is reactivated in the ophthalmic division of cranial nerve 5. It represents about 1/4 of all cases of herpes zoster, and patients present with periorbital vesicles or rash. Now, the thing is that a lot of people, ooh and ah at what a herpes zoster outbreak looks like, but it's really the long-term sequela that is the debilitating conditions with the herpes zoster. And a lot of these patients will have chronic ocular inflammation. They can have loss of pain, or they can have loss of vision, or they can have debilitating pain from prolonged nerve irritation. So history, these guys are going to have a history of flu-like symptoms, malaise, a low-grade fever that lasts up to 1 week before a rash even appears. They're also going to have like the prodromal pain and tingling. And signs and symptoms include periorbital vesicular rash, Hutchinson sign, unilateral symptoms. You'll have keratitis, uveitis, and pain with intraocular pressure increase. So on the right-hand side, that's a Hutchinson sign, and the tip of the nose is involved, so you can pretty much guarantee that the eye is involved in that And you can look at the gentleman's pupils. You can see differences between his pupils. And so that's a good presentation picture of herpes zoster ophthalmologis. So treatment for these, you want to start these guys on antiviral medications within 72 hours after the appearance of the rash to reduce ocular involvement. And the most common antivirals are acyclovir, valcyclovir, famciclovir. If complicated by anterior uveitis, you may have to do topical corticosteroids and cycloplegics. Fungal keratitis is most commonly seen after a corneal injury involving plant material or in an agricultural setting. So again, these farm workers, people who work around trees, a limb comes back and slaps them in the eye, and they can have plant material deposited on the eye and cause this fungal keratitis. Eyes with chronic ocular surface disease. So if somebody has chronic ocular surface disease, so an example of that, somebody whose eyes are chronically dry, they can have this chronic ocular surface disease where they're set up for corneal abrasions and corneal ulcers. And then also you can see these in contact lens wearers. So the corneal, if you look at the cornea, you might have multiple stromal abscesses with relatively little epithelial loss, and you must do a corneal scraping and culture on media suitable for fungus. So this isn't something that people have laying around in their office, and therefore these guys, if you have any clinical suspicion that this might be a fungal keratitis, you have to send them to ophthalmology because of these special medians that we have to diagnose this. So because of this and the late delay in diagnosis, these guys usually have increased issues. Treatments include topical antifungals, systemic antifungals, and you may have to do corneal grafting. So here's an example of someone who had surgery and then developed a corneal fungus. And I like this picture because you can see this feathery appearance of the fungus growing, and that's the hallmark on physical exam, is this feathery appearance on the edges. And again, here's another picture, again, this feathery appearance of the edges of the fungal infection. Acanthamoeba Keratitis, again, is commonly seen in contact lens wearers. And these guys are the ones who don't have contact lens solution, so they just run it under normal tap water, or they wore their contact lens while swimming, showering, or in the hot tub. And the cause of agent is Acanthamoeba. And signs and symptoms include pain, blurred vision, photophobia, excess tearing, and foreign body sensation. So you really have to get a good history and specifically find out, one, if they wear contact lenses, and then two, if they've participated in any of these risk factors for this. And again, this requires to have a corneal scraping or confocal microscopy, and the treatment is topical biguanides, probably the only effective primary treatment. And you can give them systemic NSAIDs, and they also may need corneal grafting down the line. So here is what an acanthamoeba looks like under corneal grafting, and here it is on physical exam. And then you have keratitis that's due to environmental exposures. So there are basically two types, and that's exposure keratitis and photokeratitis. So exposure keratitis is due to dryness of the cornea caused by incomplete or inadequate closure of the eyes. So the patients may have an entropion or ectropion where the eyelid turns out, and so the eye doesn't close tightly. So the eyelid, whenever the tears wash over the eyes, the cornea isn't getting as hydrated as it normally would. And then there's the photokeratitis, which is due to ultraviolet radiation exposure. And you see that, and we call that snow blindness for those who've been out on the slopes and didn't wear goggles, or welder's arc eye for those who've been welding and didn't use goggles. So corneal ulcer is most commonly due to infection. There can be non-infectious causes that we've kind of already talked about, and that's exposure keratitis, chronic dry eyes, or severe allergic eye disease. But it's typically due to some sort of infection. Signs and symptoms include red, painful eye with photophobia, tearing, circumcorneal injection, and you may have discharged. And delayed treatment can lead to intraocular infection or corneal scarring. And when you have that corneal scarring, that will throw off the visual acuity, because now no longer is the cornea nice and smooth. Now it will have divots in it, and all this will, in the long term, can affect the visual acuity. So treatment, you have to treat this based on what the cause is. So here's an example of that corneal ulcer, and you can see this big divot in the cornea, and if that heals, it may not heal in a nice, smooth fashion. Now, if you move that same corneal ulcer right smack dab in the cornea, that's going to affect the visual acuity long term. The last two things we're going to talk about is episcleritis and scleritis in this section. Episcleritis is self-limiting, it's reoccurring. It's an idiopathic inflammation of the episcleral tissue that does not affect vision. It's more common in young adults, and it's greater in females than males. And you're just going to see this hyperemic edematous. You may or may not have some raised nodules over here, and you'll just have palpebral conjunctiva that's normal. So this is self-limiting as well, although these people are very distressed because nobody likes to have this red appearing eye all the time. So you can give them topical corticosteroids, prednisone, acetate 1%, or you can do topical vasoconstrictors. Again, this may come back. It may have times when it waxes and wanes. It's problematic because it doesn't look pretty, but in general, there's no real underlying pathology that's going to interfere with vision or anything like that. Now, scleritis, on the other hand, it's the inflammation of the sclera. It is relatively uncommon, but must be differentiated from episcleritis. And about 50% of these cases have an associated systemic disease, such as the connective tissue disease or an autoimmune disease. And the risk factor for this is male greater than female, and it usually occurs around 40 to 50 years of age. Signs and symptoms with this, there is pain. So that's a big differentiator between episcleritis. This one does have pain, redness, they will have photophobia, and they will have decreased visual acuity. And they're going to complain of the fact that they were woke up from the middle of the night and they have this boring, lancinating pain in their eye. And they're going to have discolored sclera with a blue hue. So the back, you're going to have that same red appearance, but there's going to be a blue undertone underneath those red vessels. So treatment, you can treat this medically by treating the underlying systemic disease. You can use topical corticosteroid drops, topical NSAIDs, systemic corticosteroid drops, or systemic NSAIDs. And you may have to perform surgery if you have scleral thinning. So again, here is episcleritis, and if you look past these tortuous vessels that look the same as what you would see in episcleritis, underneath you can see this blue hue. So this is definitely more concerning from a medical standpoint. And if they do not already have an underlying connective tissue disease or systemic disease, such as an autoimmune disorder, you do need to send them on to have them worked up for that. We're going to talk now about glaucoma, and there are two types of glaucoma: acute angle closure glaucoma and chronic open angle closure. So let's talk a little bit about the pathology or the pathophysiology, the normal pathophysiology. So aqueous humor is made by the ciliary bodies, and it runs in front of the lens and behind the iris in the and then in the posterior chamber, and then goes through the pupil into the anterior chamber, and then is drained out in the trabecular meshwork. So when we say acute angle closure glaucoma, for some reasons in acute angle glaucoma, which we're going to talk about in just a second, this is closed. So it closes and the fluid builds up. In chronic open angle glaucoma, this trabecular meshwork and the drainage system out the canal of Schlemm is open, but it just doesn't drain as fast. So here's a picture of that angle being closed. The iris pulls back and it closes up over top of that trabecular meshwork and the canal of Schlemm, and the aqueous humor can't get out, and it builds up pressure in the anterior chamber. So I like to tell people that acute angle closure glaucoma is like putting a stopper in a bathtub. If you put a stopper in a bathtub and you turn the water on, eventually the water is going to overflow. So that's acute angle closure glaucoma. As opposed to chronic open angle glaucoma, I like to tell people that's like a hair clog in a drain. The water will eventually get out of the tub if you have a hair clog, but it just drains slower. So acute angle closure glaucoma is counts for less than 10% of all glaucoma cases in the United States. So it's not very common in the United States, but it is very common in the world. And so signs and symptoms with this, I like to tell people, because of these signs and symptoms, you don't have to worry about you finding them, they're going to find you. So they're going to have severe pain with blurred vision due to the closure of that pre-existing narrow interior chamber angle. They're going to have halos around lights, and they're going to have extremely rapid onset of symptoms. They also may have some headaches. They may have nausea symptoms as well as this starts to progress. So risk factors for this is the elderly, the Asian or Inuit population, because they have congenitally a smaller anterior angle. That's why this is very common elsewhere in the world. You go to countries in Asia, you're going to see this more commonly than you do here in the United States. And it's also more common in those who are farsighted based on the anatomy of their eye. They have a smaller anterior chamber as well. So on physical exam, you're going to have increased intraocular pressure. It can get as high as 55 millimeters of mercury. If you look at a normal range of intraocular pressure, depending on what references you look at, it's about 12 to 15 millimeters of mercury. I like to tell people that if you don't have a tonometry pen or some way to officially measure someone's intraocular pressure, you can literally palpate the eye. Have the patient close their eye and you palpate the left eye, you palpate the right eye. One's going to feel kind of like a boiled egg that you have take the shell off, and the other one is going to feel like a golf ball. It's going to be hard. So if you look at their eye, they're going to have conjunctival injection, corneal epithelial edema. They may have a mid-dilated non-reactive pupil. They're going to have a shallower anterior chamber, and again, that eye is going to be hard. The cornea may have a steamy appearance to it, and the person may have nausea and abdominal pain. So treatment for this, you have to bring down the intraocular pressure emergently, so you have to get these guys an emergent ophthalmology referral, and you can do that with IV acetazolamide, IV mannitol. You want to do beta blockers, a mitotic agent, and a laser peripheral iridotomy. And somebody has asked me previously, well, why do you want a mitotic agent? So you would think, some people think, oh, you want to make sure that the opening for the fluid to get out between the lens and the iris is big, but actually what that does is that pulls that iris back even further, closing the opening. So here again is a really good example of when we talk about that steamy cornea. On the left-hand side, you can see it kind of looks like the cornea has been in a shower and it has like that steamy appearance over top of it. And then you can also see the fixed mid-dilated pupil on the left-hand side. So chronic open angle glaucoma is seen very commonly in the United States. It accounts for about 90% of all glaucoma cases. But unfortunately, these guys go undetected. And we call this the silent thief of sight, because this is a very slow progressing disease and people start having issues and they don't even realize they're having it. So it's usually a slow bilateral increase in intraocular pressure, and it leads to loss of peripheral vision. So this is due to the increased production of aqueous humor and blocked trabecular meshwork. But it's just, again, that's the hair clog in the drain. The water's not getting out as fast as it normally does. And it affects the peripheral vision. And most people don't even know this is happening. The people will have a loved one bring him in and say, hey, there's something going on with him. He's trying to change lanes and he's looking over his shoulder and he's about to hit cars because he doesn't see the cars that are in the other lane. So the peripheral vision starts to go and the patient doesn't even know it. So risk factors include increasing age, family history, and history of diabetic. It has increased frequency in Afro-Caribbeans, Africans, and Hispanic. It usually occurs more frequently in this group at an earlier age and also has more severe optic nerve damage. Signs and symptoms include initially there's none that they don't even know that they have it. They'll eventually have loss of peripheral vision over the years, leading to tunnel vision. On physical exam, you also might see pathological cupping of the optic disc. And treatment for this is prostaglandins, beta blockers, pilocarpine, and laser trabeculoplasty. Now, the one thing that I want to talk about real quick is with the beta blockers. This group of patients will typically be diabetic and they may have heart issues as well. So you have to be careful giving people drops that are beta blockers because they can also affect the heart. So they have to be given instructions on how to use a beta blocker and that the beta blocker doesn't reach the systemic blood circulation and affect the heart as well. So here is just a glaucoma wrap-up slide. There are a couple other types of glaucoma. There's secondary glaucoma, which is a lot of times due to injury, and then the congenital glaucoma. And so this is, again, just a wrap-up slide to kind of help you compare. And now we're going to talk about posterior eye disorders. And this is where ophthalmology gets its bad raps in the PA community. So in a PA community, when we're taught in physical diagnosis lab while we're in PA school, you're asked to hold your ophthalmoscope and you're supposed to tell all these wonderful, great things that you see in the back of the eye, which, because the eyes are not dilated, you don't get to see all the wonderful things that you're going to see in the pictures in the slides that I see. Without a dilated eye, you're not getting a very good visual of what the back of the eye looks like. And so that makes us nervous as clinicians because we don't get to practice on a dilated eye, so we don't get to see a lot of the structures in the back. So I do want to say that the pictures in this next section of the slide deck are all on dilated eyes. And so this is really hard to see without dilation. So we're going to talk about macular degeneration, optic neuritis, papilledema, retinal detachment, retinal vascular occlusion, and retinoblastoma. So macular degeneration is most commonly a permanent visual loss in elderly due to atrophy of the outer retina. And risk factors include whites, females, family history, smokers. So the signs and symptoms of this is planeless, gradual progressive bilateral central vision loss. So these guys really start having problems just seeing anything, and they have distorted images, and they're going to come in and say, I don't know what's going on, my vision's just messed up. And on physical exam, when you dilate the eye, you look in the back of the eye, you're going to see retinal drusen bodies, which are just yellow deposits around the macular region. And treatment for this is angiogenic injections or laser photocoagulation. So again, here is a picture of macular degeneration. And on the picture on the right-hand side, I like this because it just kind of lines everything out. You have the optic nerve, and you have the macula, and then you have that area, those yellow drusen bodies around it. Optic neuritis. This one is pretty unique as well because the patient is going to complain of sudden unilateral loss of vision and pain with extraocular movements. And a lot of times this is associated with systemic diseases such as MS or viral infections such as measles, mumps, and varicella. And so if you have somebody come in who is diagnosed with optic neuritis and they are not previously diagnosed with multiple sclerosis, you have to work them up for that as well. In signs and symptoms, they're going to have loss of color vision, and they may also have a relative afferent pupillary defect. On physical exam, they're going to have optic nerve swelling, and they're going to have flame-shaped hemorrhages. And the way we treat this is IV steroids. These guys should not receive oral steroids, as this might increase the reoccurrence rate. So here is an example of optic neuritis and those flame-shaped hemorrhages, and you can clearly see the optic disc is distorted here. Papilledema in and of itself is not a diagnosis. It is a sign or symptom of something else underlying, and it's swelling, typically due to swelling of the optic disc, typically due to intracranial pressure, and it can occur unilateral, but most times is bilateral. And the etiology is pseudotumor cerebri. You may have tumors, inflammation, edema, encephalitis, and you may also have intracranial hypertension. So if you see papilledema, that usually is telling you there's something else going on inside the head that you have to worry about. Signs and symptoms are enlargement of a blind spot, and they may have associated loss of visual acuity, and so you have to target the cause. Start them on acetazolamide, do some neuroimaging, and depending on the cause, you may have to do optic nerve sheath fenestration or lumboperitoneal shunt, again, depending on what the underlying cause is. So here is an example of papilledema, and you can see the bulging disc. The cup to disc ratio is also out, so the cup should be about a third of the disc, and you can see that the cup is much more than a third of a disc here. So retinal detachment, you can have two different kinds. You can have spontaneous, or you could have traumatic. And what happens with retinal detachment is the retina literally pulls off the back of the eye, and you can see down here in this bottom picture, it's almost like wallpaper coming off a wall. You can see it's pulling away in this upper outer section. And signs and symptoms include blurred vision without pain, redness, often with flashing lights or new floaters. So the risk factors for this is if you've had a recent cataract extraction, if the person has myopia, if they're older, if they have history of trauma. So my daughter has a myopic eye, and the reason why someone who has myopia is increased risk for this is the eyeball is longer. So it's longer than normal, putting more stress on that retina to stay attached. So when my daughter goes in for her eye exams, they always talk to her about if you have flashing lights or new floaters, you need to be seen sooner than later, because of the fact that her eye is longer and it puts more stress on the retina. So physical exam, you may have a hanging retina in the vitreous, so that's what this picture down here in the bottom looks like. And it's most commonly seen in the superior temporal region, so you see up here in this top outer, because that's where the most pressure is. And treatment is immediate referral, cryotherapy, or photocoagulation. Now we're going to move on to our central retinal vein occlusion versus our central retinal artery occlusion. So a central retinal vein occlusion, these people will have sudden painless monocular vision loss, often upon waking in the morning. They have risk factors of glaucoma, hypertension, diabetes, cardiovascular disease, or use of oral contraceptives. On physical exam, they'll have disc swelling, venous dilation, retinal hemorrhage, cotton wool spots. Treatment includes, you have to treat the macular edema with laser treatment or intravitreal injections of VEGF, and severity of the initial loss is a good guide to the visual outcome. So again, this is monocular vision loss upon waking in the morning, and they generally have some sort of underlying systemic disease. Central retinal artery occlusion is sudden, profound, painless monocular vision loss. If greater than 50, you have to think that the person might have giant cell arteritis, and you need to do carotid and cardiac. You need to look at carotid and cardiac sources of emboli, and you do this by duplex ultrasound, ECG, and echo. So again, risk factors include those underlying systemic diseases such as diabetes, hypertension, hyperlipidemia, oral contraceptive use, and systemic vasculitis. And on physical exam with these, if you look in the back of their eye, they're going to have pallid swelling of the retina. They're going to have cherry red fovea. They're going to have attenuated retinal arteries, and emboli might actually even be visualized. You may actually see the if you think that the person could have giant cell arteritis, you need to do a SED rate and a C-reactive protein, and emergent treatment as needed. So you want to lay these people flat. You can do ocular massage and high concentrations of O2, trying to dislodge whatever the embolus is. You want to do IV acetazolamide, and they may have to do anterior chamber paracentesis. Giant cell arteritis, you're going to put those people on high-dose corticosteroids and do a temporal artery biopsy. And retinal embolism due to AFib or hypercoagulative state requires anticoagulation. And here's what the two look like. Very, very different appearances when you dilate the eye. And you can see this just has this pale look to it, and these have the more dramatic look, but just as concerning. Finally, I want to talk about retinoblastoma. Retinoblastoma is a rare cancer that starts in the retina, and it usually develops early in childhood, typically before the age of 5. So you're not going to see adults with this. This is a pediatric illness, and early detection is extremely important because this can be fatal to a child. Almost half of these children have a hereditary genetic defect, and it's can also be caused by congenital mutation to chromosome 13. And on signs and symptoms, you're going to have leukocoria. They're going to have a white appearing pupil when trying to get a red reflex. They may also have deteriorating visual acuity as this tumor grows in the back of their eye. They may have a red irritated eye and a newly developed squint. And on physical exam, you pick this up by an abnormal red reflex, and it's confirmed by doing a CT or MRI. So the interesting thing is that the average diagnosis of these children occur between ages 12 and 18 months. And ironically, it's normally because an adult in their life becomes concerned and brings them in. Now, why do I point this out? And why do I have the well baby check over here? So we do well baby checks at 5 days, 2 weeks, 2 months, 4 months, 6 months, 9 months, 12 months, 18 months. So how many times has this child should have been gotten a red reflex, and as this tumor grows, the red reflex should become distorted? And so I drive this home to you that if you do work in a pediatric population, it is imperative that I don't care if it takes you 5 minutes to get a red reflex, you have to get a red reflex during your well baby exams. So treatment priority is to preserve life of the child, then preserve vision. These kiddos may have to lose an eye in order to save their life. Treatment with external beam radiotherapy. They can also do brachytherapy, radioactive implants, thermotherapy, laser coagulation, and systemic chemotherapy. But again, the purpose is you have to save the life and then worry about saving the eye. And a lot of times these kids will lose an eye if it's diagnosed, later in life, like around 2 or 3 or 4, in order just to save their life, they'll have to lose an eye. So prognosis depends on early detection, and 95 to 98% cure rates with early detection. If this blastoma moves outside of the eye, they have a much worse prognosis, and the cancer can spread to their brain, spinal cord, bone marrow, and lymph nodes. And there's a smartphone app called Cradle. It's a computer-assisted detector of leukocoria, and it was developed by a guy named Brian Shaw at Baylor University, whose child had retinoblastoma. And you can just use this app and try to get the red reflex. It's just something that's kind of neat that you may hear about. You'll see Facebook post where a friend across seas noted that they didn't see a red reflex on a photo of a kid. So it's the same kind of thing. This smartphone app may help early detection. So all my material came from up-to-date and current medical diagnosis, which are the current medical diagnosis is what is typically utilized for the PANCE and PANRE. If you all have any questions, please feel free to reach out to me. My email address is reid, REID, _ N as in Nancy, E as in Ellen, @lynchburg.edu. I hope you all have a great conference in Virginia, and I look forward to meeting you in person.